Sundowning syndrome is not a diagnosis as yet. It's also known as nocturnal delirium. But it's been around a long time in the literature. It was first described in modern medicine in 1941 by a British physician named Cameron. And in fact, he called it nocturnal delirium. And, you know, quite simply, it's a behavior that occurs mostly in older patients, with or without dementia, but usually with dementia. And it occurs as darkness falls. Now, you might say, well, what are you talking about here, Dr. Weiss? I live in Alaska. We have darkness 20 hours of the day for months at a time. But typically between the hours of 4 p.m., say, till 9 p.m. It's controversial, all sorts of criteria, but after sunset, okay? And of course, the mystery, the puzzle is, why then? Why not at another particular time? And the short response is we don't know with precision, but we're getting a better idea, kind of like focusing a telescope. It's a blurry picture, but we're starting to zoom in on it. But what's it look like? So sundowning can look like a lot of things because, and sometimes it can look like several behaviors all mixed together, and you can see them there. You know, not only does the patient seem more confused than their baseline, but they also look quite nervous, tense, restless, truly restless. And maybe that restlessness expresses itself in aggressiveness or agitation. They might start to move more, but move randomly, not move purposefully, wander. And they're harder to redirect, okay? And maybe they even become loud and verbal. So this is, you know, kind of a composite picture. It might be one or two of those behaviors, might be all these behaviors, but it's as darkness falls, okay? And, you know, what differentiates this sundowning from delirium is that these behaviors are universally worse in the evening, whereas delirium can be god-awful at, you pick it. Could be 2 in the morning, 8 a.m., what have you. So how common is this Sundowning syndrome? Well, the nuns told me never to do a double negative, so I must be being, you know, difficult. It's not uncommon. So I guess I could have just simply said it's common. Forgive me. So if you look at the literature, these are patients of all conditions, that is to say, dementia and non-dementia, and it ranges from as low as 2% up to a quarter of folks. But if they have known dementia, and of course the most common type is Alzheimer's, that range suddenly, like an accordion, expands dramatically. We don't know much about whether there seems to be gender or race prevalences, meaning this is an equal opportunity syndrome, a nasty syndrome, gender or race, that it doesn't differentiate. So what are the risk factors? Well, this is kind of the hottest area right now, and it's only going to heat up, and you've heard me say this before. So when I went to medical school, I know I got at least 40 hours on the Krebs cycle, which I still have not employed, but I imagine it's coming. And in 4 years of medical school, I got 1 hour of instruction on sleep, you know, a physiologic state that we spend a third of our life in. So sleep is finally starting to get the attention it richly deserves, because it's just an amazing physiologic state in so many ways. And it's really getting a lot of attention because it's clearly tied into health. You know, I often tell medical students and residents that, in my humble opinion, sleep is a medicine. Restful sleep is a powerful medicine. But what we do know is that as we all age, this is the bad news, but in particular, as we age and we have dementia, damage begins to occur to a very specific part of our brain that's called the suprachlasmatic nuclei. I can only say that twice a day, so I've said it once. So this SCN, very deep in the brain, beneath the hypothalamus, and we've got just an immense amount of data that this is a sleep-promoting center. And it's driven by really primitive things like light and temperature, and it's also driven by neurotransmitters, strange neurotransmitters that you don't hear much about. You know, we hear a lot about serotonin and dopamine and norepinephrine, but these are neurotransmitters like galanin, my personal favorite, orexin, histamine. Well, we know about histamine. So this suprachlasmatic nucleus is the sleep promoter, and there's abundant evidence. And then, geez, I forgot the biggest neurotransmitter in the SCN, the prime driver is melatonin. Our brain produces melatonin, and we've got just great evidence that melatonin helps us induce sleep and maintain sleep. And it's a protein that is triggered by darkness. Okay, so as darkness falls, we get more of it. As light occurs, fades out. So we think that probably a risk factor for Sundowning syndrome is that this SCN becomes damaged, much like the hypothalamus. You know, we lose volume, we lose neurons, damage occurs, and with this damage, we also lose cellular physiology and metabolism. There's clear-cut losses of melatonin as we age. So we've got smoking gun is too strong a word, but maybe we've got a suspect here, okay? So a risk factor. Of course, you say, well, what can I do to pump up my SCN? Right now, we don't know, but stay tuned. I promise it's on the horizon. Another risk factor, environment. So the next time you've got some free time, I would like to suggest, if you haven't already, go visit a nursing home and a memory care unit, and just stroll around, but go at a certain time. You know, maybe go at 9 in the morning, and then waltz by at 5, and just see if there's a difference in terms of, what do the French say, the je ne sais quoi, but, you know, see if there's a difference in terms of the ambient lighting. See if there's a difference in the staff. I realize we have change of shift. We have the day shift, 7 to 3, the night shift, 3 to 7, and the graveyard shift, 3 to 11, and the graveyard shift, 11 to 7. But one of the risk factors is there something going on in the environment, the patient's environment, in terms of their exposure to light or the lack of, their activities during the day? Are they now getting exhausted, depleted? Have they been paced, if you will? The noise level, disruptions at night, you know, particularly in units that provide care. We've got bed alarms, beepers, buzzing, nighttime medication dispensations, usually with electronic carts that make a lot of noise. And then we've got these babies. Everybody's got one. So there's just all sorts of possible distractions. So just go to a facility in the morning and at 5 or 6 at night and see if there's a difference. But, you know, just listen and look and see if there's a difference. And then lastly, we've got medications. So what do we know about medications? They have serum levels. Some are quick on, quick off, like an antibiotic. Some start out at low levels, reach a maximum concentration or maintain. So if people are getting morning medicines, what's happening to them at 3 o'clock, 4 o'clock? Those medicines might be starting to drop in serum concentration. And then lastly, what's the poor soul, that patient's multiple medical conditions. So imagine that you have congestive heart failure, type 2 diabetes, so your blood sugars are swinging all over the place, and you've got some lousy arthritis, and maybe you've had a hip replacement and a knee replacement. And that's just for starters, okay? And you're going through your day. And you know what? Those are all weights that one is carrying. And as time passes, you wake up, maybe you've got some energy and you're refreshed, but as you go through the day, things are starting to break through, pain's starting to break through, you're starting to wear thin. So all these tiny pieces, but if you add them all up cumulatively, they carry a weight. So the current thinking, what do they call it, the conventional wisdom these days, is we think that maybe sundowning has a lot to do with circadian dysregulation. So as mammals, we're all fellow mammals, we operate on I think it's actually a 24.2 rhythm. And you say, how'd they come up with that? Well, they took healthy young people and they put them in total darkness for days at an end, and they watched how often they sleep and how often they wake up. And there's this very predictable pattern of when we go to sleep and when we wake up, even with no stimulus. Okay? So one of the theories about sundowning is that perhaps folks that sundown, that have dementia, that they're getting inadequate exposure to light early in the day. And this is coupled with damage to the SCN and decreased melatonin production. And then if we add to that, as darkness falls, what happens? I have a lot of patients that say, I'm getting to that place where I have chosen not to drive at night. Well, gee whiz, we've got halogen headlights and lighted highways and superhighways. But, I'm 62 and, I'll just be honest. Sometimes I'd rather not drive at night. I'm not sure why. It's just a little trickier. So lower lighting. We've got shadows, lots of shadows, okay? And, this, if you already have a baseline of confusion, we've now taken it up a notch, okay? And then, as we talked about, there's really good evidence from imaging that the SCM is starting to shrink, and there's good evidence from those brave patients that have agreed to lumbar punctures that melatonin levels are falling. So perhaps this is the cause, okay? So if you run with this, you say, well, maybe we can put in some stoppers here. So first off, can we correct circadian disruption with exogenous melatonin? And I've become a big fan of melatonin, although it's tricky, because if you and I go to the health food section, you'll see 50 brands of melatonin. And you'll see doses ranging from 0.3 to 300 milligrams. And you'll say, what's a body to do? And my recommendation is you call over the health food section supervisor and you say, kind sir or madam, which is the most reputable brand here? Got it. And you're looking for 3 milligrams. That's the dose that's been studied. But here's the kicker. You want to dose it way before bedtime, not at bedtime, way before bedtime. And it's helpful. It's helpful. Now, what about sleeping pills and anti-anxiety medicines, aka benzodiazepines? So the sleeping pills, we've got a bunch. We've got the old ones, Restoril, Dalmane. They have incredibly long half-lives. So you dose a patient with them, and they're knocked out. They're knocked out till 10 or 11 the next day. So what hath God wrought? Or you use a short-acting one, like maybe Ambien or Sonata, and they're out for, 1.2 to 4 hours, and then they're up wandering. So, there's a time and a place for everything. And then, of course, the benzodiazepines, they're not approved as sleeping pills, but they're often used that way. Xanax, short-acting, Valium, incredibly long-acting, Klonopin, long-acting, Ativan, intermediate-acting. The danger here is in the elderly, and perhaps this is topic number 2, is, and another medical mystery, in the elderly, more so than in younger people, you can dose patients with the benzodiazepine, and instead of calming them, it makes them more excited and agitated. So this is fraught with worsening this syndrome. And then what about pulling out what I always call the heavy artillery, atypical antipsychotics? Well, we've talked a lot about that. It's certainly not an FDA indication, but it's done, and I think this is reserved for that patient where sundowning involves, very evident aggression and agitation, where there's danger, where there's safety risks. And then, forgive my misspelling, there was a single study that noted benefit with an acetylcholinesterase inhibitor, a dementia drug, the first, Aricept. But this is just a single study, and you always want to put your money on studies that have been replicated. So these are pharmacologic thoughts. But let's move over to non-pharmacologic, and we've already hinted. Can we have lights on early in the morning, 9:30 to 11:30? There seems to be some benefit here for sundowners. And we even have doses. You can buy light boxes that give you specific doses. It comes in something called a lux, which is a measure of luminosity at a certain distance, okay? And then pain management. Perhaps this sundowning is they got their dose of Tylenol or Tramadol at 7 a.m., and, these medicines are wearing off. So should we look at pain as a possible intervention? I can't tell you how many elderly people have told me that they take a Tylenol at bedtime and it really helps their sleep. And my fantasy is they have arthritis, and when they twist and turn, it wakes them up, but the Tylenol is just enough to kind of suppress that amount of pain, but that's my fantasy. And then, of course, the whole behavior modification program that caregivers in memory units and assisted living units and nursing homes are so skillful and graceful and beautiful at doing, redirection, reassurance, distraction. That's all more than worthwhile. It often is enough to soothe the patient. And maybe that segues into, what is it? Music hath, what's the quote? Music hath powers to soothe the savage beast. I really massacred that one, but you catch my drift. So music therapy, aromatherapy, simulated presence therapy, this is where technology really is useful now, because we can put up the iPad and we can Skype with their distant beloved relatives, or we can play a video of the grandchildren, and maybe that'll soothe that sundowning patient. And then, of course, sleep hygiene. Are they is their routine for sleep decompressing them, or is it stimulating them? I used to always never understood, being in some facilities where, after dinner, they'd have a very rousing sing-along, which was great, but I thought maybe they should have timed that before dinner, I don't know, or earlier in the afternoon. But I think most facilities have figured out a routine. And then, of course, and this is easier said than done, as one mammal to another, the longer we're up and the more we're doing, the sleepier we become. It's just kind of physiology. So whatever can be done for these patients to be active earlier in the day will probably be somewhat helpful, with the caveat that you don't overdo it. So what a tightrope, huh? What a tightrope. have to walk that tightrope between too much and not at all. And I wish I could give you a better guideline. So you know, the short piece, the summary, this is common, much more so in patients with dementia. And it's a mighty challenge. It's almost like caregivers dread the passage of time and the fall of darkness. And we're pretty sure it probably has a physiologic basis. Lots of things appear to be helpful. As we said, there's nothing that's the given cure, but they're all worth trying. And you know, like we always end these, you know, we hope and pray for a cure. We do our darndest to relieve the symptom or the presentation, but the one thing we can always do is provide care. So that's Sundowning in a nutshell. So thank you.